Welcome to the control ventilation. This is going to cover sort of how your brain gets the signal to breathe and how you sort of execute your breathing cycle and different things that go into it. This one is kind of a fun subject because when you look in critical care medicine, you'll see people with different traumas, different injuries, different acid-base balances, and they'll have different breathing patterns. And so it gets into how their brain is acting, and the way someone's breathing can actually be an indication of how healthy their brain is in some situations. So let's go ahead and just start with the basics of how you get the signal from your brain about breathing, and then how the signal goes from your brain and what parts of the brain activates what types of breathing that you'll have. So let's go ahead and get started and just go over this. This is going to be a lot of repetition, but remember, repetition is going to be the key to success here when we're talking about getting all of these things down. So when we're looking at the regulation of breathing, it is automatic. It requires no conscious awareness. You will breathe with left to your own devices. You will still be breathing. And breathing originates in the brain stem. So this is going to be the big one. One of the things that we look for if we do a brain death protocol on a patient to see if someone has brain death is to literally turn off the ventilator from delivering a breath. And when we look at that, we're going to see after a period of time, usually it's around 10 minutes or so, after a period of time, if the patient starts breathing on their own, if the patient doesn't take a breath, the whole time period that we've allotted for them to try to take a breath, that's a sign that their brain might have had a severe injury and they might have declared brain death. Now, when we do brain death protocols, just as a little side note here, we do multiple things to determine brain death. We don't just do the ventilator test. We do a bunch of other things. You with the neurologist, with the nurse, with so on and so forth. We work together and do multiple tests before someone is officially declared brain dead. And so if you want to get into brain death declaration protocols and things like that with donating organs and things like that, very interesting stuff, I think. Some people aren't so into it, but just let me know. I think that it's a very interesting field to get into, very rewarding, especially working with donors or recipients of organ donations. And it was always a bittersweet feeling taking care of someone that was going to donate, someone that was declared brain dead, and then their organs are going to be donated to those that need it. It's a very rewarding but bittersweet at the same time situation. You're as much as possible taking care of a hero, someone that's going to save the lives of multiple other people. So it's a whole different thing. There's also like religious things and legal things that go into it, so it's very different, very complex subject, more than what I want to get into here. But hopefully you feel ready for going through how the brain and the lungs interact. Now remember, this is automatic. You don't have any real control over this. However, you do have some voluntary control. In other words, you could tell yourself breathe faster, breathe deeper, and you'll do so. You could tell yourself to breathe slower, breathe shallower, and you will do so. We do have some voluntary control, and that voluntary control too can help control things like emotions, anxiety. Very, very amazing stuff that the breathing can affect, especially with how our brain functions and how our emotions function as well. So these are the areas that we're going to be talking about. One of these is cut off. It's supposed to be medulla oblongata, right? Like what it says here in the picture. The medulla oblongata, but I wanted to make sure you had a nice view of the brainstem. And the brainstem is what we're looking at the right side there. We're going to be looking at a couple areas. We're going to be looking at the pneumotaxic center. We're going to be looking at the apneustic center, the DRG, which also has the VRG. So that's what we're looking at here. So the brainstem includes the pons, the medulla oblongata, and the spinal cord. And so spinal cord injuries, if they're high enough, can also affect breathing. If you know who Christopher Reeve was, he was an actor and activist that played Superman in some of the Superman movies as well, and he was I think thrown off of a horse, if I remember right. It was a equestrian injury, and he had a spinal cord injury that was pretty high, and he ultimately had to be on a ventilator. There are people that if they get a high enough cerebral spinal cord injury, they will have to be on a ventilator as well. There are some cases where we could do, and I believe I've talked about this with you guys before, a diaphragmatic pacemaker. It's pretty cool. It's just like a pacemaker for the heart, but for the diaphragm. As long as there's phrenic nerve intervention to the diaphragm, we can use that pacemaker. So if the injury is low enough on the spinal cord where it does affect their breathing, but we still have nerve intervention, then we can use that pacemaker. But other people, if the cerebral spinal fracture is too high, then they may not be able to have that nerve intervention, and therefore may not be a candidate for that diaphragmatic pacemaker, which is pretty cool. The advantage of a diaphragmatic pacemaker is that patients no longer dependent on a ventilator. They go in for the surgery, we place the electrodes in their diaphragm, we set the depth, the rate, and then they come back out of surgery and they're not connected to a ventilator. Right, and it's a very emotional response because these people, some of them had been on the ventilator for years, and they had no idea how liberating it is to not be connected or dependent upon that machine. Instead, they just got this little pacemaker in there. It's pretty cool. So hopefully we'll talk about that more in second semester as well. So these are the three areas: the pons, the medulla oblongata, and the spinal cord. All will affect how you breathe and the breathing signals. The respiration regulation. So this is where we're looking at is the respiratory center of the brain. There are two of these centers in the medulla oblongata. So they're called the respiratory center. You have your dorsal respiratory group, the DRG, and your ventral respiratory group, the VRG. So let's get into what they do. The dorsal respiratory group, which is this first one, contains mostly inspiratory neurons. Taking a big breath in. They innervate the diaphragm and the external intercostals. Now, these are the normal muscles of quiet breathing. Normal quiet breathing, right? We talked about you're just using your diaphragm. It's only about maybe 1 to 3 centimeters of movement. Your external intercostals, there's some data that says that they fire as well with each breath. So there's other data that say that they're not necessarily as involved as they once thought they were. So for now, I'll say there's thought that they are involved, and there's thought that they don't have a significant role. It's hard to really prove at this point, but both of these are going to be primarily your quiet respiratory muscles, your normal quiet breathing, what you're hopefully using right now, unless you're like running on a treadmill while you're listening to this. This group, the DRG, functions in every respiratory cycle. The key word here is every respiratory cycle, whether it's a quiet breathing or you're forced breathing, right? You're running a full sprint down a street, right? This is going to be used with forced breathing. You're blowing out candles. It's used with forced breathing. You're taking a deep breath because you've seen a ghost, right? Forced breathing, right? So the DRG is in use no matter what. Every time you take a breath, whether it's you're actively thinking of doing it or whether you're passively doing your breathing, it's going to be used in every respiratory cycle. Remember, quiet exhalation is passive. So we have the DRG, and it's mostly inspiratory neurons, and that's what's used during every respiratory cycle. The VRG is a big accessory, and the VRG is looked at in forced breathing. So if we need to take extra effort, we can recruit the VRG. So the VRG is not in every respiratory cycle. It's only in forced respiratory cycle. So this is more for active exhalation. Active exhalation. So this is blowing out candles on a birthday cake, right? Really hard, right? Or blowing into a pulmonary function machine. Or, right, it's that active forced exhalation, right? So this is your internal intercostals is primarily what they'll look at. They also do some abdominals, things like that as well to shorten the rib cage and make it more of a forced effort. This one not only does active exhalation, but can also help with maximal inhalation as well. So this is your kick it into overdrive. This is your extra gear in your car, if that makes sense to you. It innervates also the sternocleidomastoids, the scalenes, all those muscles that help increase the diameter or the strength of the depth of the breath in as well. So if I really need to force a breath in and force a breath out, my DRG can recruit and use the VRG. So DRG is the driver. The VRG is your very powerful friend. That's how I remembered it. It's my very powerful friend because the VRG is used for forced inhale, forced exhale. DRG is used no matter what, but it's your primary driver there. So the dorsal respiratory group located in the posterior region of the medulla oblongata. So if someone tells you that a patient had a stroke near this area, or if there was brain swelling like encephalitis, or a brain bleed, things like that that suppress or push the medulla oblongata, or if the brain stem is being pushed through from the skull into the herniating into the spinal column, this is an area that can be really affected and cause that brain death. In other words, where the patient can't breathe on their own or anything like that. The DRGs, mostly, like we talked about before, inspiratory neurons. You're going to see a lot of repetition here. It's for your benefit. And this is responsible for your just basic rhythm of breathing, right? This is what's going all the time. This is your driver. This is what sets the pace and what allows you just to have that basic rhythm of breathing. So the VRG, remember this is the very powerful friend. This one has both inspiratory and expiratory, but this one we can do forced inhale, forced exhale. All right, so this is also located in the medulla oblongata, right? But it's in different regions. The other one was posterior, okay? So two different regions in the medulla is the VRG, and we'll look at a picture after this. There are 3 subsections here. Okay, the nucleus ambiguus, which is the first one here that we'll talk about, is inspiratory neurons that look at the laryngeal and pharyngeal muscles using the vagus nerve, the cranial nerve, right? So when we're looking at this, I had a patient who, and I probably already told you the story, I had a patient who we were going to take off the ventilator. We're going to extubate, right? Take the breathing tube out. They had a stroke. They were in our neuro ICU, and the primary physician was like, yeah, let's go ahead. The critical care primary physician said, yeah, let's go ahead. She did well breathing on her own through the machine. So she had good respiratory drive. She wasn't working hard. Her heart rate, her blood pressure, everything looked beautiful to take her off of the breathing machine. So when I pulled the tube out of her throat, when I extubated her, her ability to breathe stopped. So she was working hard. She was using her abdomen, her stomach, her diaphragm, her accessory muscles were going, right? She was trying to get a breath in but couldn't. It's almost like she had something obstructing her airway, like someone with obstructive sleep apnea, where something's stuck in the back of their throat. So she could not draw a breath in. And later on, we had to reintubate her. We could not get her to stabilize without that breathing tube in place to sort of keep her throat open, because her throat just closed down and she had no control over it. So when we had to reintubate her, and then the neurologist came through and said, "Oh, I'm not surprised. I didn't know for sure, but the area that she had her stroke, that was affected by her stroke, I should say, was an area that could have involved the nucleus ambiguus." And to us, we're like, what does that mean? And that's why she had very poor laryngeal, pharyngeal muscle tone. In other words, she didn't have the ability to use those areas to keep muscle tone of her throat. Isn't that crazy? So her throat collapsed on itself whenever she was trying to breathe. And so that was a result of where her stroke, what was affected by her stroke. So with her case, we ultimately did put a tracheostomy tube in because we didn't want to leave her on the ventilator. That's cruel. So we put a temporary tracheostomy tube in, and then later on speech therapy love speech therapist. The speech therapist was able to work with her and help her get that muscle tone, and the neurologist and everything to get her on the recovery path to where we were able to eventually take out her trach and she was able to breathe just fine. So, little side story there, but it's an application of why this could come in handy. If we would have both collaborated, if we would have been on the same page with the neurologist, we would have been like, okay, what's our game plan if she doesn't have muscle tone, or if there was a test we could have done to see if she does have that muscle tone before we would have taken the tube out and avoid some of that extra stress on her. That would have been very helpful. So there's a lot of application to what we're learning here, and I'm just hopefully giving you just one little glimpse of just how handy this information can come in. Another section is going to be the retroambigualis. So retro means behind, so the nucleus retroambigualis. There's two subgroups within here. You have the rostral, which is towards the head, and the caudal, which is towards the tail. So the rostral is mostly inspiratory neurons that stimulate the diaphragm, and the external intercostal. So those are for breathing in, right? The caudal, which is towards the tail, is mostly your forced expiratory area, and this stimulates your internal intercostals that squeeze the rib cage internally, or close the rib cage, which means you're going to force a breath out, and also your abdominal muscles, so you can force a breath out, right? If you take a deep breath in right now and then force a breath out as hard and as fast as you can, you're probably going to, without even thinking about it, use your abdominal muscles and use your internal intercostals, right? Because you're using your VRG, your ventral respiratory group. It's your very powerful friend to the DRG. The last subgroup, so we have three subgroups. We have of the VRG, we have the nucleus ambiguous, the nucleus retroambigualis, sorry. You do need to know these two subcategories, the rostral, which is inspiratory, and the caudal, which is expiratory. And then your final big subgroup here, right, the third one, is your Botzinger complex. So this contains expiratory neurons as well, and they inhibit the discharge of inspiratory neurons. So this makes sure that you're absolutely done exhaling before you take the next breath in. So instead of exhaling and then in the middle of your exhale, somehow you take a deep breath in, that's what it prevents. It says, okay, I'm going to let you exhale completely. So that way you're going to be able to get rid of all that CO2. You're going to be able to get rid of everything you're trying to get rid of before that next breath starts. So it stops you from breathing in before you're done exhaling. It's, hey, slow down. We're getting rid of some CO2, and then you can go ahead and inspire. All right, in the pons, there are two more centers. So we were just in the medulla oblongata with the DRG and the VRG. Remember, the DRG is during all respiratory cycle. The VRG is a very powerful friend that helps you with forced inhale, forced exhale. And then you have your three subcategories, right? Your retroambigualis, the pneumotaxic, the retroambigualis, the Botzinger complex, so on, right? In the pons, so this is a different area than medulla oblongata. So in the pons, there are two more centers. We have the pneumotaxic and the apneustic centers. Now, the way I remembered where one was over the other, one was on top of the other. If you guys ever remember what a taxi is, right? Some of you may know what a taxi is. This is before all those rideshare things. They always had a sign on top of their car, and so that's how I remembered which one was on top. But the pneumotaxic center and the apneustic center. The apneustic center will prolong a breath in or cause you to hold a breath. And holding your breath, right? And this is that inspiratory phase. Apneustic breathing is something that you will also see sort of end of life with patients. As their body becomes very acidic and they're not compensating anymore. It's one of those like gasping final breaths that you'll see is where they take that apneustic type breathing where it's that prolonged inhale and then they really don't have a fire to exhale. It's just the last part of their DRG sort of, not their DRG. Well, the DRG gets the signal from the apneustic center and then holds it there. The pneumotaxic center inhibits the apneustic center normally and promotes exhalation. So the pneumotaxic center, right? The pneumotaxic center will stop you from taking an inhale pause. So if you take a breath and pause at the top of your breath, right? The pneumotaxic center is like, wait a second, stop it. Stop it. Cycle into exhalation. Go into exhalation, right? So the pneumotaxic center is responsible for being a check or a balance against the apneustic center. So in your brain right now, both of these are going off. You have your apneustic center that wants to hold your breath, but you have the pneumotaxic center saying you don't really need to right now, so I'm just going to promote you to exhale, right? So this is how they sort of work together. It's like that beautiful dance where you have your apneustic center says take a deep breath in, and your pneumotaxic center says release it back out. Take a deep breath in, and your pneumotaxic center says okay, release it back out. And so this is what sort of creates that transition between inhalation and exhalation, right? And so when you're looking at the pneumotaxic center, it says stop it, stop it, stop it, right? And says cycle into exhalation. You don't need to inhale and pause it right now. So this is what we're looking at. This picture on the right should make a little bit more sense with the when we're talking about the pneumotaxic and in the pons, as well as the apneustic center in the pons, and then we talked about the medulla oblongata having the DRG and the VRG. So the pneumotaxic's on top here, right? And it's primarily saying, hey, cycle into exhalation. The apneustic center is also in the pons, and it's saying, hey, slow deep breath in and pause, but the pneumotaxic center will say, be like, you don't really need the pause, go ahead and cycle out. Then you have the medulla oblongata that has the DRG, which is during every breath that you take, and then the VRG, which is your very powerful friend for forced inhale, forced exhale. Remember, this one includes the Botzinger's complex, the nucleus retroambiguous, and then the nucleus ambiguous. So the Pontine respiratory center, which is the pons, right? If you hear or see this out there in literature, in critical care literature, in neuro literature, they might call this the Pontine respiratory center, especially when you're talking about brain death protocols and things like that. So the Pontine respiratory center includes the apneustic and pneumotaxic center, and even though the DRG is what drives things, they get their signals. The DRG gets its signals from the Pontine respiratory center. So the apneustic center is located in the lower portion of the pons. Remember, taxi, right, is on top, so that's how I remember this. So this is in the lower portion, right? Apneustic's below it, lower portion of the pons. It continually sends impulses that tell inspiratory neurons of the DRG and the VRG. So like I said before, the DRG gets its signals from the Pontine center, or from the apneustic and pneumotaxic center. So the apneustic center is all the time telling your DRG to fire. If your apneustic center is saying, hey, you need to take a big breath, well, it'll tell the DRG, take a big breath. That will then tell the VRG, hey, help me out here. And the VRG is like, okay, I can help you out, right? And then it'll help you take a very big breath. So I always remember this as very big friend or very big breath. Inhale, very big breath. Exhale, right? Very. So when the apneustic center is not inhibited, in other words, the pneumotaxic center is no longer fighting. So when this center is not inhibited, it'll cause that gasping breath hold called apneustic breathing. And this is what you'll classically see as someone's last couple of breaths, or the very short period before they eventually pass away. So this is the apneustic breathing. So if you walk into a room and a patient's not supposed to be breathing, they're not an end-of-life patient, and you start to see this, start to worry very much, especially if they're not supposed to be doing that. That's a bad sign. The pneumotaxic center, which is located in the superior portion of the pons, and this gets neural impulses from the vagus nerve, right? So the vagus nerve will tell us about the lung inflation reflex and stretch receptors, right, that are from the intercostal muscles. So it tells us, have you taken a deep enough breath? And these are sensors, right? The inflation reflex and the stretch receptors in the muscles are saying, you've taken a big enough breath. I don't want you to pop a hole in your lungs. So go ahead and exhale, right? Because if I just keep inhaling, and I don't have my rib cage, I don't have these muscles to tell my brain stop it, then in theory, I could take a super big breath and pop a hole in my lung. Right, especially if I had a disease like emphysema or something like that, where my lungs had more of a propensity to do that, where they were sicker, right? So this is a safety or that helps you from inhaling too far and causing an issue. Now, it's not perfect, but it works, right? It's one of those continuous things that works. And what we're going to see here is that as the lungs start to reach that whole that the end of their inflation, as the muscles in the rib cage sort of reach their stretching limit, it's going to send a signal to the pneumotaxic center saying, hey, stop breathing, because remember, it inhibits the inspiratory neurons, and then it'll let you cycle into exhalation. So the big thing here is to limit how deep of a breath you're taking, right? And that's a protection mechanism. It wants you to not overstretch and pop a hole in your lungs, especially if you have a lung disease. And this is what we're looking at once again. Remember, you have your Pontine region, which has your pneumotaxic and your apneustic center. Remember, the apneustic center is inhibited by the pneumotaxic center. And the pneumotaxic center is important because it limits your inhalation. Well, how does your DRG and VRG get their signals? Well, they get their signals from the Pontine respiratory centers. It gets it from the apneustic and pneumotaxic center. So the DRG and the VRG are controlled or get their relay signals from the pneumotaxic center. So even though I talked about the DRG being the driver, it's continuously going, it's getting its directions. So imagine that being like a smartphone or something that tells you where to go, like a map, like a Waze app or something like that. It gets its direction, the DRG and VRG, the medulla oblongata, get its input or direction from the Pontine center, which is the pneumotaxic and apneustic center. All right, so we talked about sort of the signals that go to the brain and which ones sort of control how to breathe. Remember, Pontine sort of controls everything, and the medulla oblongata has the DRG and the VRG that sort of execute the directions that the Pontine center gave us. So what about respiratory reflexes? We've talked a little bit about these, and this is ultimately going to be modified by different things on how we feel or physiological things that are going on with our body. So chemoreceptors are going to be the most sensitive things that will cause a lot of different respiratory reflexes, and this is more on the autonomic part of things, all right? So when we're looking at chemoreceptors, they're very sensitive to CO2, pH, and oxygen content of the blood or cerebral spinal fluid, CSF, right? So, and we'll talk about each of these individually. The next one's going to be blood pressure changes, right? And that's going to look at the carotid and aortic sinuses to sort of tell us what's going on there. Right, the third part that's going to affect us is our stretch receptors. We've already talked a little bit about this, and we'll bring up the term Herring-Brewer reflex here. And then the fourth one here is going to be physical or chemical stimuli in the respiratory tract. In other words, if you inhale dust or fume that you're not supposed to be inhaling, which you're not supposed to inhale any type of dust or any type of fume, but that's a whole separate thing. But if you're inhaling an irritant of some sort, then it's going to cause respiratory changes. It's going to cause a respiratory reflex, hopefully. That's the plan, is to hopefully cause a reflex. And then there are other things, and you guys know this as well, like you've all lived enough, that you know that someone's pain, someone's emotions can affect how they're breathing, right? We've all seen the people that have anxiety, and they breathe deep, they breathe fast. It's that hyperventilation thing, and it's a real thing. And that's where it comes in. I had a patient once, I knew her very well. She was someone that we interacted a lot with respiratory therapy, and she came in and she was having an asthmatic episode, a severe asthmatic episode, But she was having anxiety and embarrassment with it as well. She was embarrassed that she was back. She was anxious that all of us were in the room and working with her. And it's just a whole environment that's very sad, because having the pain and emotions that she was going through actually made her breathing even worse, because she was breathing faster and harder than she would if she was more relaxed. And the anxiety actually made her asthmatic episode worse, to the point where we had to put her on a breathing machine. It caused her to trap more air, and it caused her to have more issues than if she was somehow calm. And I'm not saying it's easy to be calm in that situation. I don't think any of us, unless we had extensive sort of conditioning there, could be calm in that situation. So please just understand, in the future you have a patient comes in, put yourself in their shoes a little bit. Like, still, you're doing your job to help them, but understand they're going through embarrassment and pain and emotions, and that if you're able to sort of be a calming factor in that room and just address them and say, hey, I'm so and so, I'm with respiratory therapy, I'm here to help you breathe a little bit better, and right, just be that calming presence. If you're hyperventilating as the respiratory therapist, if you're nervous, if you're showing your nervousness and your fear to the patient, that actually might be feeding into their anxiety, and it could actually cause them to get a little bit worse. So this is where I just want to encourage you guys to keep that, understand what the patient's going through, and then sort of use that, understand it, that you need to have that sort of sympathy to understand that, hey, I need to be that calming presence. Not only do I need to know my craft, but I also need to do other things that can ultimately help the patient out in the end. So just be aware of that. All right, so let's talk about the first one. The first one is talking about the CO2, the oxygen level, and the pH level in the bloodstream. So you have what's called your central and peripheral chemoreceptors. So the centrals are located in the medulla, and the peripherals are located in the carotid and aortic arch. Okay, so let's talk about these. The central, which is located in the medulla, responds to hydrogen ions, right? The hydrogen ion concentration is your pH balance. So this is the one that your brain, as long as you don't have emphysema, right? As long as you don't have a chronic CO2 retention problem right now, this is the one your brain primarily uses, is the hydrogen ion level, the pH level, right? And so that's why it says over here indirectly the CO2, because that's going to sort of what control your hydrogen ion level for the most part. So the brain, the medulla, looks primarily at your hydrogen ion concentration. There are peripheral chemoreceptors, right? These are the ones that are located in the aortic arch and the carotid sinus. And these look at a bunch of different factors. Not only do they look at the hydrogen ion concentration, but they also look at the CO2 and the oxygen concentration. Notice it doesn't say saturation. It says PO2, which is your P little AO2, right? So it looks at P little AO2, it doesn't say saturation. So we got to be careful about saturation here. But of these, pH and CO2 are the most important, but still less so than the chemical chemoreceptors, right? So when we're looking at the chemoreceptors, the central one, which is in the medulla, right? Notice I'm making a big deal about this, and this isn't the first time you're seeing this. I'm repeating this. Hint. Central chemoreceptors are located ventrally along the surface of the medulla, and they respond to hydrogen ions, right? The pH balance of the patient. It's the most powerful stimuli to the respiratory components, right? So when the central chemoreceptors are stimulated, they transmit a signal to the DRG and VRG, which are responsible for the rhythm of breathing, right? We talked about the rhythm of breathing being responsible, right, between these. When we're looking at this, right, it gets the signals. We send the signals via the cerebral spinal fluid that there's too much hydrogen ions. Like, let's do an example. We got an acidosis. So we got a lot of hydrogen ions, right? And they go to the via the cerebral spinal fluid, and they go to this area of the brain, and the brain says, oh, you've got too much acid going on, so I'm going to stimulate the DRG, which is your normal one, and the DRG is going to then recruit the VRG, its very best friend, to take very big and very fast breaths to help get rid of these hydrogen ions. So when your VRG takes very fast, very deep breaths, hopefully it helps regulate that hydrogen ion situation. Right? So this is sort of how it works. So you're looking at CO2 levels increasing in your blood, right? So the CO2 molecules will diffuse across the membrane that separates the blood from the cerebral spinal fluid. That's what you're seeing here. And this membrane is called the blood-brain barrier. And hopefully you cover this in regular A&P as well. And so that CO2 crosses the blood-brain barrier. Of course, as you know, CO2 will ultimately, when it combines with water, this is the carbonic acid equation, it's just going vertical this time, will form carbonic acid H2CO3, which then dissociates into bicarb and hydrogen ions. Well, the hydrogen ions will stimulate the central chemoreceptors to breathe faster, breathe deeper, or let's say there's a very low hydrogen ion concentration. Let's say we're in an alkalosis. Well, the low hydrogen ions will tell the DRG, VRG, they'll tell the DRG, hey, slow down, right? And that's where you might see someone's respiratory rate of like 8 or 6 or something like that. It's telling it to slow down so it retains CO2, so that way it helps regulate that acid-base balance. Right? As the CO2 moves into the cerebral spinal fluid, it breaks down, right? We talked about this in the carbonic acid equation. It breaks down into bicarb and hydrogen ions. When it sees the hydrogen ions, it stimulates the receptors to breathe faster and deeper. Well, the inverse is also true, right? If we had low hydrogen ions, it would stimulate the central chemoreceptors to decrease ventilation. So in this situation, high hydrogen ions, which means you're in an acidosis, should stimulate it to increase ventilation. This increased ventilation should help ultimately reduce the arterial CO2 level and the pressure of CO2 in the cerebral spinal fluid. So when the pressure of when the hydrogen ion concentration in the cerebral spinal fluid decreases, that's when we'll go back down to a resting state of rate and depth of breathing. So this will then decrease the hydrogen ion concentration in the cerebral spinal fluid, and then the stimulation will be like, we don't need to do it anymore because we regulated everything, and therefore you should go back down to a normal quiet breathing. So what's an application of this, Derek? So let's say you're working in an emergency room, a patient comes in and they have a respiratory, let's say a metabolic acidosis. So a patient has a severe metabolic acidosis, they're breathing fast and deep, and then we do something, let's say they're dehydrated. We give them fluids, right? We give them an IV of fluids, tons of fluids going into their system. They're able to buffer them, right? Because we need water for this whole buffering situation. So we're able to help them buffer and take them out of a metabolic acidosis. So once we do this, right, their hydrogen ion level should decrease, and therefore we should start to see their respiratory rate and their tidal volume start to decrease, right? Their minute ventilation should start to go down if we've helped correct that acidosis that's going on. Did I need a blood gas to show that we're correcting it? No, I just was looking at their breathing. If their breathing looks slower and more shallow after we've instituted the therapy that helps them, then that could be a sign that we're actually being therapeutic, that it's helpful to that patient. Right? So ultimately, that's why I said it responds to changes in CO2, even though it's hydrogen ions, but we know that CO2 with the carbonic acid equation leads to hydrogen ions. So you sort of see where I'm coming at there. So it responds to changes in CO2. What about the peripheral chemoreceptors? What's their job? We talked about the central ones, and it's primarily pH Well, what's their job? Well, they're sort of like a backup quarterback or a backup, you name it, a bench player for a sports team, sports ball, whatever it is, right? These are more oxygen sensitive. These are more oxygen sensitive. These are more oxygen sensitive. Do you see what I'm stressing that? Okay. They respond to lower oxygen levels in the blood supply. So they're located in the neck, right, at the bifurcation of the internal and external carotid and in the aortic arch. That's why they're called the carotid and aortic bodies. And they look at PO2. They look at how much oxygen is going to the brain. And your brain, just like your other organs, likes oxygen, right? Your heart likes oxygen, your kidneys, your liver, like all those things like oxygen because that's how your body sort of survives, because it needs oxygen and removal of CO2. All right, so the other one looked at pH, unofficially CO2. This one's going to be looking at oxygen. So now we have a good dichotomy. We have a good balance. We have a good dance partner here, right? We have one that looks at oxygen and one that looks at pH. Okay, so they're in contact with the arterial blood, which sends things to the brain for nourishment or to the organs for nourishment. And these are only activated, right? They're only activated with a low PO2. Now, this PO2 is going to be less than 60 millimeters of mercury. All right, so if it's lower than 60 millimeters of mercury, it kicks the peripheral chemoreceptors into drive and says, okay, breathe. Because your oxygen levels are low, I need you to breathe. Okay, so what's the big thing? Why 60? Why 60 before we cause your breathing to increase? Well, here's the thing. Do you remember this whole oxyhemoglobin dissociation curve? And anything above 60, we had this sort of safety zone that was going on where we were able to have good saturation. We were able to carry a good amount of oxygen to our tissues and saturate a good amount of oxygen so we could carry it to our tissues. So that's what it's looking at here, is it's actually saying if your PO2 is above 60, you don't need me. You're carrying and transporting a good amount of oxygen to your tissues. But if your PaO2 is less than 60 millimeters of mercury, then I'm going to kick in and say breathe faster, breathe deeper, right? So it's not activated until the PaO2 is reduced to less than 60 millimeters of mercury, right? To reduce to less than 60 millimeters of mercury. So as someone's oxygen levels start to drop, their P little AO2 is dropping, and their P little AO2 hits 60 or below, it's going to activate the peripheral chemoreceptors and say, hey, breathe faster, breathe deeper. Here's an interesting fact, right? This response of you breathing faster and deeper is then turned off if your PO2 goes below 30 millimeters of mercury. So if you're between 30 and 60, your breathing, your respiratory rate is increased, right? You're breathing fast, right? You're trying to ventilate more to get oxygen into your bloodstream, right? Get CO2 off of the parking spaces, get oxygen into your parking spaces, right? So you're trying to breathe fast. But if your CO2 level goes from 60 to 30 and then less than 30, so let's say it's 29, well, then your respiratory rate changes. So now over here, your respiratory rate, let's say, goes to like 5, right? So your respiratory rate decreases if you go below 30. And this is called the Moro reflex or your dive reflex. This is something that babies do. If you plan on working NICU, babies will do this a lot too, where they stop breathing. Because most of them, if they're premature, they stop breathing because they're not supposed to be out yet, and they're supposed to be relying on mom's umbilical cord, right? They're supposed to be relying on her life support system, so they're not supposed to be breathing anyway. So when a baby's oxygen levels fall too low, they stop breathing altogether. It's that dive response. And you've heard about people that have drowned in like a cold lake for like an hour and somehow they're able to still be alive at the end of it. Not warm water, but cold water. That's a whole separate thing you'll get into emergency medicine about. But when we're looking at this, your body shuts down, and it's doing that to save itself. So it's turning the system off. It's going into sleep mode. It's doing this on purpose to save itself, because do you use oxygen? Do you use your metabolic rate to breathe fast and deep? Absolutely. If you want to reduce how much oxygen your body's using, so your brain has more left over, so your organs have more left over, you need to shut down that system to reduce oxygen consumption. So when it gets to less than 30 millimeters of mercury, it shuts down your breathing system to help conserve what oxygen you do have in your bloodstream to keep your brain and your heart and your kidneys going. Isn't that crazy? It's called that Moro, that dive reflex, and you'll see it more common in kids than adults. Peripheral chemoreceptors, patients with chronically high CO2 levels. So we're looking at usually emphysema here, or severe lung disease, right? COPD. They may rely totally on their peripheral chemoreceptors to control their ventilation. Remember, the peripheral chemoreceptors look at oxygen. The central chemoreceptors look at hydrogen ions. So the big difference here is that someone that has chronic CO2 retention, like emphysema, their oxygen levels are going to be very important at determining how they breathe. Because what's happening chronically with their hydrogen ion balance? Well, chronically, the hydrogen ion balance is increased, right? It could still be within normal limits. Let's say it's 7.35. It's within normal limits, but that's still an increased hydrogen ion level, so the brainstem won't respond nearly as much to this hydrogen ion balance increase, but what their brain's going to now respond to more is going to be their oxygen. So this is going to be very important for COPDs, people that have CO2 retention. Right? Now you can have emphysema, you can have chronic bronchitis, you could have all those that don't have chronic CO2 retention. So we usually have to draw blood gas to see if someone has chronic CO2 retention. But when they do, when someone does have chronic CO2 retention, they are they're more sensitive, I should say. They're more sensitive to oxygen changes in their bloodstream than you and I. Us, we primarily drive off of our medulla, which is the hydrogen ion balance. And then these patients that have chronic high CO2 levels, they thrive off the oxygen balance, because that's the one that's really going to help them the most, because they're chronically high on their hydrogen ions. Right, so patients with chronically high CO2 may rely totally on the peripheral chemoreceptors to control their ventilation. Yes, I did that on purpose. There's a reason. It's in there twice. Yes, so your patients that have chronically high hydrogen ion levels, your CO2 retainers is what we like to call them, they are a lot more sensitive to super high or super low oxygen levels in their bloodstream than those of us that do not have chronic CO2 retentions. We respond more to pH changes. Right? So chronically high CO2 in the cerebral spinal fluid inactivates the sensitivity of hydrogen ions. In other words, like I said, you're not going to respond near as well to pH changes anymore because it's chronically high. And hey, my baseline is chronically high, so therefore I'm not going to be as sensitive to a high hydrogen ion concentration anymore. So it's going to use its backup system, and the backup system is your peripheral chemoreceptors. Remember, your primary system was in your medulla and it was your hydrogen ions. Then your backup system, or your bench player, is the peripheral ones that look at more oxygen, right? And it looks at oxygen. So if your CO2 levels are going up, right, and we talked about this before, if my CO2 levels are increasing, especially when we're looking at the hemoglobin, right, especially if we're looking at the parking space availability, what's happening to your ability for oxygen to be on there? Well, your ability for oxygen to be in your bloodstream is decreased. So it also helps with ventilation as well, because if we have a high CO2 level that builds up above our baseline, it's going to read that we have a low oxygen level, and therefore use in the peripheral chemoreceptors are going to see we have a low oxygen level because our CO2 level is high, higher than normal, and it's going to tell our brain to breathe faster and deeper through the pons, and then ultimately into the medulla oblongata, tell your DRG and VRG to breathe deeper and faster. Right? So it's more sensitive to the pressure of oxygen in the blood, not the content. Remember we talked about the CaO2, which is how much is on the hemoglobin and how much is in the plasma. So it is not looking at CO2, it's not looking at CaO2, it's not looking at hemoglobin at all. It's just looking at plasma. So we need to be aware of conditions that have a normal oxygen pressure, right, in the plasma, but an abnormal CO2. So this could include anemia. Anemia, you have very low hemoglobin, right? You don't have very much red blood cell. Your ability to carry oxygen through the workhorse, which is the red blood cell that does most of the carrying, is decreased. So my CaO2, if I were to calculate my CO2 with anemia, it's going to be decreased. My CO2 is going to be decreased because I don't have much hemoglobin at all, and therefore my PaO2 is going to be fine. I'll have a normal P(a)O2, but my content, my ability to carry oxygen is decreased. So if I have someone that has COPD, here's an application point for you. If I have someone that has COPD or chronic CO2 retention, and their PO2 is just fine, but they become anemic, their body's not going to tell them to breathe faster and deeper, even though their organs are getting hypoxic, even though their organs are not getting the oxygen level they deserve. So this patient could easily go into altered mental status and all these other situations by just being anemic. Right. Another example of this would be carbon monoxide poisoning. Carbon monoxide poisoning, you'll have a normal P(a)O2, right? That'll be normal. However, the hemoglobin molecule, it's not low that we have hemoglobin like we had anemia. The hemoglobin molecule will have low oxygen levels. So our ability to carry oxygen is decreased, right? Because remember, over 200 times more attractiveness to carbon monoxide than oxygen when that's present. So carbon monoxide causes an anemic hypoxemia as well. So it's a form of anemic hypoxemia, and that's going to show a normal PO2. So this patient that has chronic CO2 retention, okay, what's the situation? I have a patient who is in a house fire. He was smoking. He was in a house fire. His cigarette fell on his bed. It caused everything to fall on fire. He woke up. He has chronic CO2 retention. Was able to get out of the house. Had carbon monoxide poisoning as a result of this fire. So on and so forth. His ventilation may not be triggered to breathe faster and deeper because his PO2 level might be normal, even though he's still not carrying a lot of oxygen. So we got to be careful with these patients that have chronic hypercarbia, because their body won't tell them to breathe faster and deeper as long as they have a stable PaO2. But as you know, PaO2 is only one very tiny way of carrying oxygen. Most of the oxygen is carried on the hemoglobin. So we got to be careful about looking at their red blood cell count, right? This is where your patient assessment comes into play. What's their hemoglobin level? What's their red blood cell count, right? Because their respiratory rate and tidal volume might be normal, even though they're going into hypoxic failure. Isn't that crazy? All right, another receptor is called your baroreceptors, so pressure, right? These are stretch receptors located in the walls of the aortic and carotid bodies, and they regulate blood pressure by initiating some reflex adjustments. These are not the same as peripheral chemoreceptors. These sort of just look at blood pressure by initiating blood pressure and breathing changes based upon blood pressure. And so remember, your breathing can affect blood pressure as well. If your blood pressure is very, very low, you might actually have to breathe faster and deeper to get what little oxygen you do have in there. And also by you breathing spontaneously, your negative pressure breathing, right? Take a big, so think mentally, think about the rib cage right now, okay? Put your hands on your right under your collarbone and then take a big deep breath in. Right, the rib cage is expanding. When that rib cage is expanding, it's using negative pressure. We talked about this before, right? Chapter 2. That rib cage is expanding and actually pulling blood in through the vena cava as the rib cage expands. So here, we're just going to draw a big box as the rib cage. And as the rib cage expands, it creates negative pressure. Right? Your thoracic cavity creates negative pressure. And that means I'm going to have a lower pressure in my inferior vena cava close to my heart compared to my veins in my legs, right? So I'm actually going to have blood. I'm going to pull blood by taking a deep breath in. I'm actually going to pull blood from my vena cava into my right side of my heart, right? So actually taking a deep breath improves preload, improves the amount of blood flowing to the heart, which hopefully would help improve the blood pressure as well. So if you think about the ventilation cycle as it also helps blood pressure, you're going to change your respiratory rate and pattern also with blood pressure based upon baroreceptors. All right, so with a decreased blood pressure, the neural impulses from the baroreceptors cause your heart rate to increase, your respiratory rate to increase. We talked about this. Because that creates that more negative thoracic pressure, it's going to increase your respiratory rate to therefore increase the amount of blood flowing into the right side of the heart, which therefore increases the amount of blood going into the left side of the heart, which would then hopefully increase your blood pressure, right? It also increases your heart rate, right? Because we need a good stroke volume. We need a good cardiac output to get blood supplied to our brain, to our heart, so on and so forth. The heart muscle, the myocardium. So we need that increase in heart rate to help with our cardiac output, to get good oxygen and nutrient delivery to our tissues like our brain and our heart muscle. Right. This is also going to stimulate us to increase the force of contraction of the heart, so the heart should squeeze harder. Just like you see if someone's exercising and you check their blood pressure, if you guys do treadmill tests as a respiratory therapist, you'll see that where we'll do a treadmill test and someone's blood pressure is higher when they're working out. And that's normal, right? Your blood pressure shouldn't drop, it should increase as you work out. And that's going to be that increased force of contraction, right? That's going to be a natural response to this type of stimulation, this low blood pressure. And obviously your body, it will release things to help constrict your arteries and your veins. That helps with venous return. That helps push that blood back to your heart and preload or prime the pump, so to speak. If your blood pressure is high, if you're hypertensive, right, super high, like in a hypertensive crisis, your baroreceptors will be like, that's too much pressure. I'm going to slow your heart rate down, right? It's going to slow the heart rate down. And the idea there is to ultimately decrease cardiac output, which should then decrease blood pressure, right? It should decrease respiratory rate, right? Decreasing respiratory rate means I have less preload, low blood, returning. If I have less blood volume returning to my heart, to the right side of my heart, that should ultimately lower my blood pressure. Decrease the force of contraction, right? If the heart myocardium itself does not squeeze nearly as hard, that will lower my blood pressure. And then dilate my arteries and veins. If I go from a vein here, right, remember Pose's law, if I have a larger radius And I had that whole Khan Academy lecture loaded on there too. If I dilate an artery or a vein, my blood pressure will decrease. Well, if I cause something that's chronically dilated to constrict, or if we give a patient epinephrine or norepi or vasopressin, which is ADH, antidiuretic hormone, if we give them those things, it'll cause their blood vessels to ultimately become smaller, or well, especially epi or norepinephrine. If we give epinephrine or norepinephrine IV drip, it'll cause those to constrict, and therefore if they constrict, remember, as the radius decreases of something, pressure increases on something, so that should help increase pressure if someone's blood pressure is low. Well, in this situation, we're going to go from a narrow vessel that's constricted to a wide open vessel that's open, and that should help reduce blood pressure ultimately, because we're having a bigger radius and therefore there's less pressure in there, right? The molecules of everything inside the blood vessel are more spread out, therefore there's lower pressure. What about the Herring-Brewer reflex? The Herring-Brewer reflex is a stretch receptor in the bronchi and bronchioles. So these are inside your lung tissue. Notice this is in the conducting zone, right? Remember the old conducting zone versus respiratory zone? The Herring-Brewer reflex is in the conducting zone. So when the lungs are overinflating, they get the signals via the vagus nerve, right? They send the signals, afferent or afferent signals, to the vagus nerve in the respiratory center, which then causes your breathing to stop. Hey, stop. You're taking too big of a breath, right? You're going to pop something, right? This is just a protective mechanism, so that way you won't pop a lung. Now, in adults, it's less significant that it can cause that. Now, it can cause it, especially if you have things like emphysema, or broken ribs, right? Then it's going to be important. But mostly we have our rib cage, where think about this as far as skeletal system goes, right? You have your thoracic rib cage that also helps prevent you from taking too deep of a breath. So this is a protective mechanism, but since we as adults that have formed rib cages, we're not going to be as reliant upon this as someone that does not have a formed rib cage, like the newborn population. So in this situation, this is me preparing you. If you work in neonatal medicine, you might see a spontaneous pneumothorax on a baby, where a baby just took a deep breath, the Herring-Brewer reflex didn't really work that well, and they just had a little pneumothorax. Now, if it's less than 20% of the thoracic space, we're not going to do anything about it, right? There's more risks than benefits of treating it. It'll resolve on its own. But this is where they're relying more on this Herring-Brewer reflex, which is located in the conducting zone, the bronchi and bronchioles of conducting zone. And that helps limit them from taking too deep of a breath and causing them a pneumothorax. However, like I said, it works. It's not perfect, but it works. The irritant reflex, oh heavens. So this one, especially for people that are in fires or exposed to fumes, tear gas, you name it, these are located, the irritant reflex is located in the trachea, bronchi, and bronchioles. Notice that this is also conducting zone. Just saying, could come in handy. Responds when it's exposed to gas, different types of gases. And your response here when you're exposed to any of these is actually to increase your respiratory rate. And you're like, Derek, wouldn't I want to not increase my respiratory rate? Wouldn't that increase the amount that gets down there? No. So this is in your conducting zone. And when you increase your respiratory rate, ultimately what you're doing is increasing ventilation. So if I increase ventilation, remember, ventilation by definition is the movement of gas. And so in theory, I'm trying to get as much ventilation as I can to get rid of the noxious gas. I'm trying to ventilate to get it out of my system. So that's why it causes you to increase your minute ventilation. Obviously, it should also cause a cough reflex and bronchospasm. Both of these are to help you from getting to your respiratory zone. So the whole idea here between these two is to stop it from getting into your respiratory zone, right? Keep it in the conducting zone, but don't get to your respiratory zone, because your respiratory zone is where you have the bloodstream intervention. That's where it gets exposed to your bloodstream, right? And so by coughing right? You're keeping it in your conducting zone. By having bronchospasm that's more significant in your respiratory zone, remember bronchospasm pretty much closes off communication to your respiratory zone from your conducting zone. And so this helps prevent that gas from getting into contact with the bloodstream. The J receptors, juxtapulmonary capillary receptors. Where do you think these are? These are the small conducting airways, and then it's between the pulmonary capillaries and alveolar walls. So these are very, very tiny ones. They're called C fibers, right? Capillary fibers. Right? And what happens down here is they're located closer to the respiratory zone. They're still in the conducting zone, but they're a lot closer, and they're sort of like the last stop when we're looking at this. And this will respond as well to chemical and mechanical stimulation. So if you get a dust or a fume or a certain inhaled chemical irritant that gets down there, you're going to have your J receptors and your C fibers be initiated. And this is going to cause you to breathe rapid and shallow. Well, what do you know about the rapid and shallow breathing pattern? Does it allow gas to get nice and easy into the respiratory zone? Or does a rapid shallow breathing pattern decrease alveolar ventilation and actually allow for a lot less gas to get to the respiratory zone? Yeah, it allows for a lot less gas to get to the respiratory zone. So if you see someone breathing rapid and shallow as a response to an irritant or a stimulation of some sort, that's the idea, is to help prevent whatever got inhaled from going to the respiratory zone. So still near the alveolar wall, still in the conducting airways, like the very small conducting airways. So we're probably looking at the transition zone, most likely here. And this is the last stop. This is also something that's stimulated with people that have congestive heart failures, because it's located in the pulmonary capillaries and alveolar walls, right? Between the pulmonary capillaries and the alveoli itself. So if we're looking at a picture, let's see, I don't have much room here. Here's the alveoli. Here's the blood vessel. And then the J receptor, let's go green. So the J receptor between the pulmonary capillaries and alveolar walls, they're sort of in the loose space. Remember, the tight space is the communication here. So they're sort of in the loose space here that sort of surround this area. So I'm just going to put like green dots there. So they're in the loose space there. And so if someone has heart failure, like left-sided heart failure, congestive heart failure, they're going to bleed into their interstitial space and into the alveoli. It's called cardiogenic pulmonary edema. And when this happens, it's going to stimulate the J receptors, and this patient with congestive heart failure is going to breathe rapid and shallow. Isn't that crazy? It's a response when someone has pulmonary edema, whether it's cardiogenic or non-cardiogenic pulmonary edema. It's a response to the C fibers, to the J receptors. And this is also something you'll see that people with HAPE, high altitude pulmonary edema, they'll also flood fluid into their lungs, right? Because there's lower atmospheric pressure, right? And they're going to have that rapid shallow pattern because they're having the stimulation of the C fibers or J receptors. What about ventilation? So the deflation reflex. So if you've ever had the quote-unquote wind knocked out of you, this is something that you're looking at here. This occurs when the lungs are compressed or deflated. Makes sense. So this is where you're going to increase your respiratory rates after this happens. So let's say you were playing a game of sports ball. I don't know, you were carrying a football and someone tackled you because they were trying to play. And somehow it knocked the wind out of you. The football was like right where your diaphragm is, and it sort of forced gas out of your lungs. And it deflated your lungs pretty severely. Well, to cause your lungs to go back to reinflating, to reinstate your FRC, it's going to tell you to breathe faster just to get you back into the game. So if you've ever had the wind knocked out of you, whether it's a bicycle accident or something like that, where the quote-unquote wind gets knocked out of you, you've stimulated the deflation reflex, and so that patient's going to hyperventilate a little bit after that episode just to sort of restore their functional residual capacity. All right, and so this is what we're looking at ultimately for the brain and the control of the heart. The carotid and aortic bodies is what we're looking at here for your baroreceptors and your PO2s, and then your brain stem is ultimately reading the cerebral spinal fluid. It's also ultimately reading the hydrogen ion concentration and making changes off of that. Based upon the hydrogen ion changes, it'll tell your pneumotaxic and apneustic center to breathe faster and deeper or not. Right? And then that your DRG VRG gets the signal to breathe faster and deeper or not. And then that will help control your acid-base balance as well. So not only is it important to look at someone's acid-base balance in their body, but also, is there something wrong in the communication? Is this patient someone that has chronically high CO2 levels and they don't respond until their PO2 is low? Well, remember, your ability to carry oxygen in your bloodstream, you could have organ dysfunction. If this COPDer was in a house fire and they have carbon monoxide poisoning, they're not going to breathe fast and deep unless their P(AO2) is low. And so that's where it's important to sort of get a blood gas and go for co-oximetry and look at the different hemoglobin concentration levels like carboxy and oxy hemoglobin and so on and so forth. So it's going to be important to sort of understand how that signal gets to the brain and from the brain to the tissues, especially if you work in a neuro critical care unit. Neuro ICU is what we had in. This is going to be a big thing to look at how our body responds to blood pressure changes, how our body responds to anxiety and fear, right? Anxiety and fear will increase that respiratory rate and the depth of breathing. And if someone has an irritant reflex, they'll cough and have a hard time. I remember I had that 18-year-old, I told you guys the story probably already, where she was a lifeguard at a pool and had a chlorine gas inhalation. Well, she could not stop coughing. She had that irritant reflex, right? You've just learned about that. That irritant reflex was functioning very well on her, and she was coughing, 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 and she couldn't take a breath. She was embarrassed. She was anxious, right? So she had a couple of strikes going on. What didn't have a strike going, she didn't have an asthma. She didn't have any of those other pre-existing pulmonary conditions. Great. That worked in my benefit and in her benefit. And so she just had that cough irritant reflex going on. And so they kept giving her nebulizer after nebulizer, but she couldn't take a deep breath because she had the irritant reflex going. Well, where the irritant reflex, remember, causes bronchospasm as part of it. So she was having a very similar to an asthmatic response. So we did systemic steroids, so steroids through the bloodstream. Right, and then we also did inhaled bronchodilators like albuterol, but she couldn't take a deep enough breath for the albuterol to get to where it needed to go to help reduce her bronchospasm for her to breathe normally. So I asked the physician what his thoughts were on nebulizing something called lidocaine. Lidocaine is something we use for bronchoscopies. It numbs, right? It has that cane part to it. It numbs the airways. We use it so when we put the camera down people's nose and throat into their lungs, they don't cough like crazy. It just numbs it. It's very temporary, but it helps reduce that stimulation and that irritation reflex when we go to do that procedure. So I asked the physician, hey, she's pretty irritated. She can't get the albuterol to go where it needs to go to help her breathe because she was having a hard time ventilating because of the bronchospasm. So the physician agreed to doing a couple of treatments with the lidocaine nebulizer. And sure enough, she was able to breathe a lot more comfortably. And then we were able to get the medicine deep enough to where it needed to go to help her sort of restore back a little bit until the steroids kicked in, of course. But just little things here and there. Make sure you go over this. Make sure you understand this information before you take the final. Hopefully, you guys are feeling confident about this, reading through this chapter as well.